On behalf of the Division of Collaborative Care and Wellness, it is my pleasure to welcome all of you to this John Romano Clinical Grand Rounds. The theme of the Grand Rounds today is integration of team-based mental health care in OBGYN. And in line with this team-based care theme, we are going to have a team of presenters joining us today. And it is my distinct pleasure to welcome all of them. I apologize that there will not be a long introduction for the sake of time, but I would like to introduce Dr. Ellen Poleshuck, who is Professor of Psychiatry and OBGYN and the Academic Chief of the Division of Collaborative Care and Wellness. Dr. Ellen Tortolo, who is an Associate Professor in OBGYN. Dr. Aspen Ainsworth, who is Assistant Professor in Psychiatry. Eileen Steichen, who is a licensed mental health counselor and leading the collaborative care as a behavioral health care manager, has been instrumental in making this program a success. Rachel Zoller, who's a senior licensed marriage and family therapist in OBGYN. And last but not least, Kizzy Lee, who's an ambulatory technician and has been really doing a wonderful job getting the program of Rose Counseling that you're going to hear about during this presentation today. A couple things to mention as well before I hand it off to the presenters. Please, you do not have to wait until the end of the presentation to ask questions. You can use the Q&A tab on your Zoom, on the bottom of your Zoom account to put questions in there. Some of them will be answered during the presentation and some of them will be left to the end to be answered live. Also, to let you know that the evaluation link for this grand round will be posted at the end of the presentation today. Without further ado, I want to again welcome everybody and hand it off to Dr. Ellen Poleshuck.
Thank you very much, Dr. Nasra. Just give me a minute here and I will share slides. So I'm really excited that we have a chance to share with you some of the work that we have been doing. I'm Ellen Poleshuck, as Dr. Nasra said. I'm going to be speaking to my role as the director of the program for mental health and gender wellness in OBGYN, and specifically some of our work at one of the practices that we have. So we have a whole team here who's going to be sharing with you our work today, and we're really excited to talk with you. So first, let me just give you an overview of what we're going to be talking about today. So first, why are we talking about integration of behavioral health in an OBGYN practice? And then we'll be providing an overview of some of the interventions that we do on a practice level, on a patient level, and on a clinician level. So Dr. Tortola, our practice director, will be talking about the practice itself. And then we have our clinicians who will be describing the ROSE, postpartum depression prevention intervention, behavioral health care management, mental health therapy, and medication, followed by a case example. And if all goes as planned, a little time for QA at the end. We have no conflicts of interest to declare. I do want to take a minute to acknowledge some of the amazing partners that we've had in being able to do this work. First, we have incredibly supportive chairs in both the departments of psychiatry and OBGYN, Ben Lee and Eva Pressman, along with funders who have allowed us to do some of the work that we'll be describing today, and key people associated with those funders who have really worked with us to help us execute this work. Thank you, Dr. Weldon, for your help with putting some of our slides together. And of course, our colleagues and our patients at the Gender Wellness OBGYN practice. So first, just to give us some context, I wanted to put a frame around this work that comes from the Division of Collaborative Care and Wellness in our our division. So, so just to point out what our mission and our vision is for doing this work. So we really are trying to do work that is bringing partnerships together to improve our ability to provide whole person care and care that's going to benefit patients and families by partnering mental and physical health together. And so many of the services that we have within the division exemplify this. Many of the people who are attending this talk are already doing this work, and we are really sharing this as one example of the work that we're trying to do. So what is integrated behavioral health? So just to share one definition with you is really when we have a team of medical providers and behavioral health clinicians working together, partnering with patients and families using a systematic approach that is cost-effective, patient-centered, and for a specifically defined population. And so when we think about integrated care, it can be used in many different ways and in different contexts, inpatient and outpatient. But we're going to be just talking about it in OBGYN. And when we look at integration, you know, there's a lot here on this slide, and I don't expect everybody to read all of this, but from SAMHSA, this is a levels of collaboration, just to say that dropping a mental health clinician in a medical practice is not integrated care. And so that really moving to, you know, a coordinated or having minimal collaboration, which you see on the left, is really when you have two systems that function pretty independently, but perhaps interact around patient care. When we have co-located care, they may be physically close to each other and have on-site care and trying to integrate, but it's not necessarily systematically organized in a way that creates seamless care for patients, and then trying to really move towards the greatest integration that we can to the right of having a transformed practice where people are really coordinating together and have a shared concept of what the vision is that infiltrates all of the way the work that is done. And we'll really be talking about our journey here from moving us towards co-located care, which we've had for a very long time, towards becoming more integrated, and our desire to do that. So just to put this into context for you, so everybody here works at the Gender Wellness Obstetrics and Gynecology practice at 125 Lattimore Road, so just a stone's throw away from the Department of Psychiatry. And it used to be called the Women's Health Practice until pretty recently. It's a large generalist practice, which has a variety of different practitioners, including multidisciplinary roles. So you can see we have residents as well as providers, and we have social work, dietitian, financial case management, and behavioral health, and care management as well. And then it's full spectrum care, including both obstetrical and gynecological care, as well as high risk pregnancy, abortion care, and chronic pain, along with other issues. And really, many of the patients that we serve are patients who are at risk for having their needs be underserved. And so many of them are individuals of color, individuals with low income who come from the city of Rochester. And so we really want to, and we really know that this is where many of them come for care, and they're much more likely to make it into our context here than they are likely to make it to a specialty mental health setting. So we really want to try and meet people where they're at and respond to their needs as best we can. So just to give you an overview of what the mental health needs of the patients here look like, you can see here, these were just from some screenings that were done in the waiting room using iPads, and you can see what our rates of distress are for patients who are coming in for appointments. So 22% had elevated depression scores, 21.6% elevated anxiety, 7.5% reported elevated alcohol use, with 14.6% of those who are pregnant reporting elevated use, and 9.2% reporting any substance use other than alcohol. So, so the need is there. And so in 2018, our goal became to really create a pregnancy medical home model and to have a practice transformation. And one of the key things we really wanted to focus on as part of this initiative was mental health, because we appreciated how important addressing mental health needs were for improving the goals that were identified, which is the health of OBGYN patients and their babies, and to have a more systematized team-based approach to capitalize on the resources we have and to fill in some of the gaps that we had. And so just to show you who our team is now, who we have a psychologist, a psychiatrist, 3 staff therapists, a behavioral health care manager, a psychiatric nurse practitioner, Rose postpartum depression prevention counselor, trainees, and a physician support specialist. And you can see the ones with asterisks are the roles that we'll be emphasizing today because they have been grown since our practice transformation. And just to quickly comment that we do also have people integrated in other practices in OBGYN, including 2 high-risk pregnancy clinics, Highland Hospital, Community OB, and Strong Fertility. But we're really going to be focusing on the GOG practice today. Okay, so I'm going to be continuing to manage the slides, but I'm going to be shifting over next to Dr. Tortolo, who is our medical director. So thank you for joining us, Dr. Tortolo.
Thank you, Ellen. Good afternoon, everyone. I'm Ellen Tortolo, and I'm an obstetrician gynecologist, and I'm also the medical director for our gender wellness obstetrics and gynecology practice. When I joined the practice in 2014 and met Dr. Poleshuck and her team, I would say we were at the point of co-located behavioral health services with some partial integration of our practices, or at a level 4 from that prior diagram that Dr. Poleshuck just showed. At that time, behavioral health providers and staff consistently participated in monthly all-staff meetings, weekly leadership operations meetings, and yearly retreats, which we had up through 2019. Since then, we have instituted or developed daily huddles, both in the morning and at the noon hour, a performance improvement team or UP team that meets monthly, and a pregnancy loss work group, all of which have representation from behavioral health. With the recent addition of a psychiatric nurse practitioner, we also have representation at the monthly provider meeting. I also want to mention that the behavioral health team has been a great resource for clinician and staff wellness, especially over the last 2 years with COVID. Next slide, please. We cannot really get started in addressing mood disorders in pregnancy unless we have appropriate screening. In 2014, we were screening for depression and anxiety at the postpartum visit using the EPDS. In 2016, we added screening at the new OB visit per ACOG guidelines, also using the EPDS. And in 2021, we added screening at the 28-week visit. Screening using tablets began in 2018, and this has really been a game changer for us. The tablet is given at check-in at the above visits, and the tech or nurse or provider does not have to remember to give the patient a piece of paper and then collect it. Screening by tablet allows the patient to answer the questions in private, and the results flow directly into e-record, so no transcribing is needed. Also, alerts come up in the electronic medical record for the provider when there is a positive screen. At this time, we also instituted screening for our GYN patients at their annual exams and for anyone establishing care as a new GYN patient. I also want to mention during this evolution of the screening process, we changed from the EPDS to the PHQ-9 and GAD-7 after discussion with our family practice department. This decision was made for 2 reasons. First was to have the ability to compare the intrapartum and postpartum screening results to subsequent results when patients typically return to their primary care provider for depression and anxiety treatment or management. The second reason was in preparation for tablet screening to be consistent with other URMC practices. Next slide. The behavioral health team also created smart phrases for providers to use when there is a positive screen. The first is the .WIP depression smart phrase that goes through the following points to make a brief assessment. It goes through, prompts the person to enter the score on the PHQ. It gives questions to ask about suicidal ideation, and there's a list of symptoms to ask about. There's also a prompt for any stressors or precipitants, concurrent substance use, prior episodes of depression, or prior treatment for depression. And finally, there's a prompt to make a safety plan and a follow-up plan. Our second smart phrase is the .whip depression follow-up smart phrase that assists in subsequent visit documentation. One of the most helpful tools that we created was this flow diagram to help with decision-making once the assessment was completed. I could not fit it all into one slide, so this is a series of 3 slides. But as you can see in this first slide, if the PHQ score is 10 or greater, you start down the pathway to the right. The next decision point comes after the assessment is completed, with mild symptoms going to the left pathway, which includes psychotherapy, self-care, mobilizing social supports, and moderate to severe symptoms going to the right pathway, which includes psychotherapy and medication. Next slide. This slide goes into more detail about medication options and management once you choose a medication. Most of you already know all about this, but for our providers who do not get much formal education about these medications in pregnancy, it has been extremely helpful. Next slide. Finally, this last portion of the flow diagram gives guidance on what to do for follow-up. All right, next slide. Over the last 7 years, more providers have become more comfortable addressing positive screens, addressing a positive answer to question number 9 on the PHQ, and starting an antidepressant medication in pregnancy if necessary. The role of the behavioral health care manager will be explained in detail later in this talk, but briefly, I wanted to say that we have initiated team-based visits where the behavioral health care manager can touch base with the patient at a routine OB visit and give critical or important information to the provider that may not have otherwise been obtained. The behavioral health care manager can also touch base with the patient in between visits by Zoom or phone, and this has been extremely helpful, especially at the beginning of pregnancy when the OB visits are 4 weeks apart. This has also been helpful during COVID when some of our normal in-person visits have been converted to telemedicine visits. Providers are also more supported in that there is almost always someone available on site if a true emergency arises. And the behavioral health care manager can come in on the fly when an urgent problem is identified and can spend more time assessing the patient for the proper level of care. Next slide. For the patients, we have developed written education materials around mood disorders in pregnancy that normalize mood disorders, provide information on symptoms to watch for, and the written materials also provide resources for patients, such as phone numbers and websites. We have also noticed better communication and coordination of care by increasing the team visits and increasing warm handoffs. There are also shorter wait times for patients to talk with someone while awaiting a formal therapy appointment, a medication consult, or waiting for medication to be effective. There are 3 initiatives that I think have moved our practice to a level 5. The first is development of the role of the behavioral health care manager. The second is expansion of the medication consult service. And the third is the integration of the ROSE program into routine prenatal care. And now I am going to hand it off to Kizzy Lee, who is our ROSE counselor, and she will explain this program to you. Okay, Kizzy, we're gonna switch places.
Thank you, Dr. Tortolo. My name is Kizzy Lee, and I'm an ambulatory technician and a ROSE counselor at GOG. I'm speaking to you about ROSE program today. The ROSE program targets postpartum depressions, which is a very common problem for patients at our clinic. In fact, without ROSE, we expect that 1 in 4 women with financial problems will struggle with postpartum depression. Outside of ROSE, healthcare is usually focused on identifying and treating postpartum depression after it starts. This is a problem for low-income families, women, because there are many barriers to getting the care they need, like no child care, unreliable transportation, or stigma about getting mental health treatment. The ROSE program is different because we start early before patients have symptoms of depression. We also offer ROSE to everybody, whether we think they're going to get postpartum depression or not. We present the ROSE program to our patients as educational, course, this helps reduce the stigma some people feel about getting mental health care. Another thing that makes Rose different from the other types of mental health care is that it can be administered by people who are not trained as mental health professionals, like nurses, health educators, and midwives. For example, I'm an ambulatory technician. In my job, I usually do things like rooming patients, monitoring vital signs, assisting providers with procedures, phlebotomy, and training other technicians. Why have ambulatory technician like me leave Rose instead of a counselor or a mental or a social worker? In my experience, I have been able to make connections with patients, and patients are comfortable with me and know me as a familiar face in the clinic and are able to relax and feel less intimidated than they might be with a social worker. Does Rose work? Yes, Rose works. Evidence from 5 random control trials show that Rose lowers postpartum depression by 50% in low-income patients, as is recommended by the U.S. Preventative Service Task Force. So what type of things do we talk about in Rose? Rose stands for Reach Out, Stay Strong, essential for mothers of newborns. The Rose program teaches interpersonal psychotherapy skills. We focus on improving communication and building support. Let's take a closer look at the program. Sessions A through D are during pregnancy. Session A focus on learning about postpartum depression, learning the differences between baby blues and postpartum depression so that the patients know what signs and symptoms they are looking for. Session B focuses on role changes that's going to come up after the baby arrives, relaxation, and self-care. Session C, we learn about how patients can get the support they need, ask for help, state what they need in an assertive way. Session D, we teach how to say no to requests. We also discuss how to identify an abusive relationship and give resources for getting help in an abusive relationship. So what type of things do, and lastly, we meet for session E about 6 weeks postpartum. In this session, we discuss how things are going for the patient, review skills, and problem solve problems that may have come up during their first weeks of having their child. Patients can attend Rose however works best for them. We offer sessions individually and in small groups. Individual sessions can be in person or by Zoom. Group sessions are currently by Zoom only. The group runs on a rolling basis, so patients can join the group at any time and complete sessions in any order. This prevents people from having to wait for the next cycle of group to start. Instead, they can start right away. It allows them to make Rose work for their schedule. They can also repeat sessions after sessions again. There is no referral process for Rose. This means that in addition to being open for all our patients at Lattimore, they do not need a doctor to make a referral. We get the word out about Rose multiple times during a patient pregnancy, prenatal care, such as through flyers, mailers, my chart messages, in person, while patients are in the office for prenatal visit. In summary, Rose is an evidence-based program, educational intervention that reduces the rates of postpartum depression in low-income patients. Rose is very flexible program. It can be administered by different types of staff member and is offered in flexible formats to reach most patients. Rose is just one of our interventions that we have here, and I will now pass it over to Aline, who will explain our intervention that she leads. Thank you.
All right, thank you, Kizzy. So I'm the behavioral health care manager, and I'm gonna do an overview of the collaborative care model that we've implemented here over at GOG. So collaborative care management is model that's used to treat common mental health conditions such as depression and anxiety in primary care setting with systematic follow-up. It focuses on defined populations that are tracked in a registry using measurement-based practice and treatment to target. The team is made up of the medical provider. So in our case, it's our OB providers, the patient, and the behavioral health care manager. The provider and the care manager work together in providing evidence-based medication and psychosocial treatments. And the team is supported by psychiatric case consultation with recommendations for treatment adjustment for patients who are not improving as expected. And we find that roughly 70% of patients need some sort of adjustment in their treatment plan throughout their course of care. Next slide. Oh. So we defined our patient population as those who are pregnant and who have a PHQ or GAD screening of 10 or above. And more specifically, those who have barriers to traditional psychotherapy, because we also have therapy services located here, which Rachel will explain next. The three biggest barriers that we do see, which I'm sure a lot of you see in your practices, is transportation, technology, and time. Transportation, making it difficult for patients to present to in-person appointments. Technology and having private space to complete telehealth appointments. And of course, time. Time is precious and hard to come by for many people. Our patients at GOG are no exception. They already need to take time off of work or need to find childcare to make their multiple prenatal appointments. So finding time for therapy often is not a priority or possible. So enter collaborative care. Patients have already identified depression, anxiety needs through screening. When that happens, the provider can refer to collaborative care, or I also monitor all the screens at their new OB visits. So I will connect with them quickly. This is important since in our population, as pregnancy is time limited. The earliest we usually see patients enter prenatal care is around 10 to 12 weeks, giving at most 30 weeks for treatment if we want to make gains before baby arrives. Not all patients present to care that early, and some might identify depression, anxiety symptoms later on during their pregnancy. We are able to begin providing interventions quickly during their already scheduled prenatal appointments, as Ellen had mentioned, and over the phone in between appointments. This eliminates the need for waiting to get in for treatment and need for any quote unquote extra appointments that they don't have time for. Next slide. So in the past 2 years since we've started, we've seen growth in overall engagement in collaborative care management services. This is largely due to adapting our workflows, provider education on the service, really getting that buy-in from our OB providers, and team communication. We have seen overall 67% improvement in PHQ scores with 47% remission in depression, 66% improvement in GAD scores with 37% remission in anxiety. And improvement in collaborative care is defined as patients whose final scores are either below 10 or have decreased by 50% and a remission under 5. So although our improvement and remission rates are good, they are not where we thought we would be. Our goal was to hit 75% improvement, but there's a lot that can explain that. So over the past 2 years, we've lived through a pandemic, which has challenged us to adapt our workflows and expectations. As you know, with the pandemic, we have seen higher rates of anxiety and depression, and our behavioral health systems were greatly impacted. So to adapt, care management actually began providing interventions to patients with the goal of transitioning to psychotherapy in some cases when intakes were available. So we took on patients that weren't necessarily suited for care management, but needed treatment more quickly given the lengthy wait list at the time. So I recall at one point, I think our wait list was around 12 weeks. Which is a very long time if you're pregnant. So we would assist those patients in the interim. With this, we were able to reduce the pressure on the behavioral health system. Other additional benefits is we reduce provider stress levels. They know their patients are being monitored in between their appointments, and we could increase provider comfort levels, specifically with prescribing. Knowing again that their patients are being closely monitored and are being scheduled for follow-up appointments as needed. All right, and now I'm going to pass on the baton to Rachel, our
Hi.
licensed marriage and family therapist over at Mental Health and
Yes.
Gender Wellness at GOG.
Yes. Hi. Thank you, Eileen. Yes, I'm Rachel Zoller. I'm a licensed marriage and family therapist and associate director at Mental Health and Gender Wellness at GOG, formerly Women's Behavioral Health Service. Next slide. So, as Eileen mentioned, at our service, we also offer more traditional mental health therapy, utilizing specifically a brief episode of care model. And yes, through the pandemic, our referral volume increased. And one of the silver linings of that was that we were fortunately able to hire an additional full-time therapist to grow our team and our service. Our team of staff therapists and psychologists offer individual, couple, and family therapy for people who receive their OB/GYN care at Lattimore Road practices. We have also started offering a DBT skills group for people who are pregnant or postpartum. And our new staff therapist, Tarika Harrell, will be starting a patient education and support group for BIPOC patients of the practice as well. One tool that helps us stay true to our brief episode of care model is a client registry that tracks things like percentage of sessions attended, PHQ-9 and GAD-7 scores over time, and it allows us to assess and refine treatment recommendations and care for our patients. As Dr. Poleshuck mentioned before, we are also a training site for marriage and family therapy trainees, psychology fellows, and psychology interns. And these learners receive training not only in integrated care, but also in common presenting mental health concerns within an OB/GYN clinic, such as perinatal depression and anxiety, sexual and reproductive health concerns, perinatal loss, pelvic pain, sexual trauma, parenting stressors, and family and relationship stress. Many of our team also work from a systemic perspective, and we often utilize this approach in treatment, encouraging patients to bring a support person to session with them should they choose to do so, offering family therapy, as I mentioned before, and prioritizing collaboration with the multidisciplinary team at GOG. One additional thing that we offer and prioritize is that trainees and staff therapists provide psychosocial consultation to patients who may be presenting with mental health needs or psychosocial stressors during their medical appointments. So in addition to interventions that Eileen and Kizzy are providing within the medical setting, the medical appointment, our trainees and staff therapists will come into appointments as needed as well. And this provides a way for patients to put a face with our service and can facilitate warm handoffs as needed. And then obviously acute mental health assessments are available and provided as necessary. One thing we also try to offer is in-person intake screens offered by our team's physician support specialist. So she can go in and meet with a patient in person who may need an urgent appointment, and they can leave an appointment with a behavioral health therapist that day. And all of these interventions and services are designed to serve our overall practice mission of reducing barriers to mental health treatment for patients receiving OB/GYN care at GOG. And so now I'll hand it off to Dr. Ainsworth.
Hi, everybody. I'm Aspen Ainsworth. I'm a faculty psychiatrist in our department. So to support the medication needs of the clinic, we have the perinatal consultation clinic. Next slide. The folks who serve the medication needs are myself and Alexa Weeks, who is a psychiatric nurse practitioner in the department, a new addition to the team, really outstanding addition to our team. The majority of the work that we do is a 2-visit consultation model. The first appointment with either myself or Alexa Weeks, and the second appointment with Alexa. The appointments are offered in person or by Zoom, and our ability to offer Zoom appointments to patients, in my experience, has really increased show rates, which has been outstanding because we get to reach more patients. During the initial consultation, and sometimes also during the second consultation, there's a general psychiatric evaluation. We discuss risks and benefits with the patient. The majority of the work that we do are perinatal consultations, so either prenatal counseling, counseling during pregnancy, or lactation or postpartum. So we discuss the risks of and the benefits of the medicines during pregnancy and lactation. And we do informed consent with the patient. We write that all up and we send the treatment recommendations and our risk benefit documentation to the referring provider. And if the prescribing provider is a different person, we send it to them as well, and any other people that the patient wants involved. Our goal of doing this is to support the patient, to really empower them with information to be self-directed about their care and medical decisions, and also to increase the education and understanding about perinatal risks and benefits of medications in our community and providers. The other mission of this service, kind of like what Rachel Zoller mentioned with the mental health therapy services, is to provide education. So we host medical students and psychiatry residents and nurse practitioner students in the clinic. An exciting new piece that we're just getting started piloting is short-term prescribing for a small subset of patients of GOG. And that's really in its infancy, but an exciting next piece. Next slide. So like I said, what we really love to do is prenatal counseling. So we love to get referrals for patients who are planning to conceive, where we can talk about the risks and benefits of medications even beforehand. We also do consultations during pregnancy, postpartum, during lactation, and for PMDD. So really any patient in the community or in any URMC practice can be referred for that. In addition to support the GOG practice specifically, we do general non-perinatal medication consultations. And typically it would be the OBGYN who is prescribing for them. If the patient has a psychiatrist and is being referred by a non-psychiatrist, we require that the referring provider talk with the existing psychiatrist first, because we want to promote collaboration with existing providers. Next slide. Referral is easy if the person has access to e-record and is a part of U of R. There's an e-record order, ambulatory referral to psychiatry. Pretty easy. Next slide. And for community practice providers who don't have access to e-record, we have a brief one-page referral form that includes patient, referring provider, who will prescribe, and some brief clinical information that can be filled out online and faxed to us. So easy to refer. And with that, I will pass it on to Eileen Steinchen.
Thank you, Aspen. So I'm going to review our case example of, next slide. So we had a young woman who entered collaborative care at approximately 19 weeks, so almost halfway through her pregnancy, with mild symptoms of depression and moderate anxiety. When she first entered prenatal care, it's important to note that she denied depression and anxiety. So it was later on during her care that she had cited some growing concerns with it. Prominent symptoms were excessive worries, fears around delivery, poor appetite. She also reports having social anxiety, specifically when around her partner's family, and will experience panic-like symptoms during this, noting that her body freezes and she struggles to move and breathe. And overall, in person and over the phone, she presents with restricted affect and is guarded. She's a shy young woman. So, next slide. Some relevant history for her. She experienced previous birth trauma, which this contributes to her fears surrounding delivery. So it makes sense that when she first came in for her prenatal care, she didn't have much on the side of depression and anxiety. But as her pregnancy was progressing, and probably with some new pregnancy discomforts, the anxiety around delivery was starting to peak. So in a prior pregnancy, she had delivered early and had placental abruption, which is when the placenta detaches from the uterine wall prior to birth, and accreta, when the placenta grows deep within the uterus. So separately, these two conditions can be dangerous for the mother. It's very rare that they occur together, but it did for this young lady, and it's a very scary experience for her. So she has that, which she didn't formally process. She has a history of untreated anxiety and untreated postpartum depression. So for women or people who have a history of depression, anxiety, that places them at higher risk for perinatal mood disorders. And specifically for people who have a history of postpartum depression, that also puts them at higher risk for having postpartum depression again. She described her experience with postpartum depression as she was isolating herself socially, had anhedonia, low energy, frequent crying spells, which she described as dissipating over time. She also has a family history that's significant for bipolar disorder and schizophrenia. She never received medication for any mental health, and she has not engaged in therapy services in the past. And again, remember, she's also guarded. So therapy wasn't necessarily, I wouldn't say it was a priority for her, but she was seeking help. And she was going with what was comfortable for her, which would be our care management model. Next slide, please. So our treatment plan for this patient relied on psychosocial interventions, including psychoeducation about perinatal mood disorders, relaxation skills training to address those physical anxiety symptoms, and cognitive processing to reframe negative automatic thoughts about one, birth, and two, social situations, specifically with her partner's family. At this time, no medications were indicated. It's also important to note that the patient at the time was not considering medications as an option for her for treating her symptoms. Next slide. Oh, perfect. Following her intake into collaborative care, we were able to meet once face-to-face during one of her prenatal visits, in which we were able to provide psychoeducation about anxiety, do some relaxation skills training, including deep breathing, self-soothing with the 5 senses, and then also reviewing how to implement these skills for when she's entering social situations, because again, at the time, that is what she was citing was most bothersome to her. And did some review of reframing negative automatic thoughts, particularly around partner's family, because a lot of her thoughts were that his family was judging her, or that they were very critical or didn't like her. So we were able to practice some of those strategies, and she was able to really grasp it and understand it. And it was nice that we were able to do it within her OB visit. There was a brief gap in care, which the patient didn't respond to our phone attempts, and then she delivered early at 30 weeks. So following her early delivery at 30 weeks, we did see an increase in depressive symptoms. Next slide. With her delivering early, that really kind of cut down what our treatment time was. We were able to quickly identify that her symptoms were not improving with our regular phone contact. After delivery, she did increase her engagement. She was now open to medication options for treatment. So with the support of psychiatric case consultation, with our case consultant being Dr. Ainsworth, we were able to communicate medication recommendations to the provider and start sertraline with a titration plan of up to 100 milligrams daily. So as the care manager, I was able to schedule the patient for a follow-up with the provider for after 30 days of being on the medication for reevaluation. And I was also able to follow up with her in between these appointments to provide education about the titration plan, which allowed her to be on the correct dose by the time she went to meet with the provider. What we see often, not always, but often in care as usual, is the provider might not know that these symptoms are worsening until the patient presents for an appointment. So that in this case would have been, 6 weeks after delivery. Then the provider, again, in care as usual, this is what we see often, not always, but often, is the provider may start the medication with a loading dose with a plan to increase it after 1 month, but then maybe the patient doesn't show up, and so the increase doesn't happen. Or what could also happen, which almost happened in this case is there is a titration plan, but the patient doesn't follow it. So the therapeutic dose is not reached by the time the patient comes back in to see the provider, which results in partial symptom relief. The patient doubts the medication's benefit, and there's need for more appointments, which the patient's already struggling to make, especially with having a newborn. So what happened here is the provider prescribed a titration and follow-up plan. The patient didn't follow the titration plan, but this was caught with the care management intervention with having our regular phone contact, because during this time we are still reaching out, providing psychosocial interventions and providing psychoeducation on the medication. She also did not attend her initial follow-up appointment, but due to our patient tracking through care management, we were also able to catch this and have her rescheduled quickly. So by the time she came in for her follow-up with the provider, she was on a therapeutic dose, she was noting significant symptom relief, and she was actively engaged in care management, following through on psychosocial interventions. So that, and you can see through our her PHQ GAD scores, they did reduce significantly. Next slide. Our key takeaway is that in this case, collaborative care treatment is flexible. We are able to respond quickly to treatment needs, adapt the care plan accordingly. So in this case, we had a plan to address anxiety, but preterm labor kind of got in the way, altered those plans, limited our projected treatment time. Providers are well supported, confident in making the treatment adjustments that are needed. Our team-based communication allows us to make changes in a timely manner and give each other updates about how the patient is responding to treatment in between appointments. So this decreases stress among myself and the providers, knowing that the patient is not falling through the cracks, and leads to our ultimate goal, which is patient achievement, partial remission of symptoms in a very brief period of time. Thank you.
Thank you very much, Eileen. And thank you to this incredible team. You can hear what remarkable work this group is doing. And we're really happy that again, our planning worked, and we have a few minutes for QA, which I think Dr. Nasra is going to facilitate for us. And so if you could take that over, Dr. Nasra, that would be great.
Thank you very much. Thank you very much. We have shout out from Jamie Treese, who's saying that she is a social worker, 8 months postpartum, and she's wants to acknowledge how a fantastic job everybody is doing. So thank you, Jamie, for that comment. There's a question from Robert Goldstein. Is there any involvement of the patient's significant other, partner, spouse, or other in this program?
So we do encourage partner involvement. Does not happen often. It depends on is the partner coming in with them for prenatal appointments. In the particular case that I was reviewing, partner was not coming in with her for appointments, but we do encourage it.
Rachel, as a marriage and family therapist, I wonder if you would want to add anything.
Sure. I think that often we are encouraging partner and family involvement. Occasionally it's an intimate partner or spouse, and other times it could be mom or significant labor support, somebody who's going to be there, particularly when it comes to patients in the perinatal population. And another thing that we see frequently is that patients may really desire the space for themselves to start, but with remission or partial remission of some of their presenting symptoms around depression and anxiety, family stressors then may become kind of the primary concern after that, and we move and are flexible around that, and the treatment focus may become a family or systemic concern. And so that's I think probably more typical in terms of family treatment for our service.
I also find with the medication counseling that often I'll have the appointment with the patient, and then when we get to the part where we start talking about treatments, they'll say, hold on, I'd like to get my partner involved. And so they bring their partner in from the other room, and they're involved in the discussion as well at the patient's preference.
One of the things I'd like to add is that I think this is a really important question, because I think when you think of an OBGYN practice, patients tend to present individually, and yet they're in the context of a family at a time where they're often going through a major life transition. And we are at risk for inadvertently focusing so much on the mother and de-emphasizing the importance of the role of other family members, whether it's a father or somebody else. And so it's something that we do talk about quite a bit, because I think it's really important to support the entire family.
There's a question regarding how is diversity being addressed in terms of patients' presentations and symptoms, ethnic backgrounds. How is that being addressed in the program?
Yeah, maybe I can speak to behavioral health, and Dr. Tortola, you can speak to the general practice after that. And Kizzy too, great. So we know that rates of mental health needs are higher among individuals of color, and that they're at risk for not feeling like the intervention fits or matches for them, or that it's a safe or acceptable option. So it is something that we have been doing a lot of work around in terms of how do we make sure that we are trying to be as inclusive as possible. And that's around ethnicity as in the question, but also race and gender identity. And really have had a lot of efforts within our team on an individual basis as well as on a team basis. And also we are trying to move towards having our team better represent the diversity of the patients that we serve, and are, as Rachel mentioned very quickly, but it might have been missed, that soon we're going to be having a group specifically for patients of color around getting support from other patients of color and navigating their healthcare. So we still have a lot more work to do in this area. We're still learning, and there are many ways in which we could be doing better. And we are working, trying to see what we can do.
Thank you. I want to mention a question from Kate Cerulli, who's having a difficult time entering it. Her question is, how do you screen for domestic violence prior to bringing in a partner?
Yes, I mean, everybody gets asked that question at every visit. Sometimes if the partner comes in with the patient at that visit, you can't really ask it. But for the most part, we do ask every visit.
And sometimes they say to say yes.
Can you repeat that?
And actually, Kizzy is saying that a lot of times with the ROSE program, it's a safe haven to say yes.
Even when asking a patient, are they experiencing any domestic violence? Sometimes this be their only chance when they get to their doctor's appointment to say yes. And then that's when we notify a provider, they notify social work, and then we start the ball rolling for some interventions to start to occur before they even leave their appointment.
Thank you. Another question, can you comment on the follow-up on pregnancy with patients already taking multiple psychotropic medications?
You want me to take that one, maybe? I mean, if they're already on medications, we don't necessarily stop them. It would be a very bad time to stop them. We usually call for help from Dr. Ainsworth or our new psychiatric nurse practitioner, who I don't see, but and find out what we should do if we don't know. But we would discourage taking somebody off their medications just because they were pregnant.
And we've recently expanded to the 2-visit consultation at Perinatal Consult Clinic. So one of the goals of that second consultation is to make sure that the medication interventions might have been implemented or followed up on, that there is an identified prescriber, just as another safety net to catch patients who might be falling through the cracks in that way.
Thank you. Jim Wallace is asking about any specific male resources to engage male partners. Anything specific that you can share?
Well, actually, we just got Marty Sandler and I, she's our lead social worker, just got a grant to develop childbirth education classes for mostly focused for people of color, but also they're going to be open to anybody. And we are also working on a class for fathers. So more to come on that. This is in its infancy. We've only had one meeting so far, but other than that, not too much.
Thank you. That's already quite a bit, actually. There's a question regarding miscarriage women and women with ectopic pregnancy and the type of resources available. Especially since and Dr. Tortolo, correct us if that's wrong, they don't come and see the OBGYN for follow-up as much.
Oh, we see all of them for follow-up after, like, especially if, there's for miscarriages, there's a couple different ways to handle it. There's medical management and surgical management, but either way, we see them for follow-up. I would say most of us do a PHQ at that point in time to see how they're doing. And then we would discuss, whether they wanted to talk with somebody about it. And then Rachel, there's a support group, right?
So yeah, so we that was one of kind of our integrated projects is I was able to work with our team of social workers and nursing staff around a outreach initiative for people who had a loss. So kind of regardless of the point in pregnancy in which the loss happens, the type of loss that's folks are channeled to a work group and receive supportive outreach in addition to kind of medical follow-up care. And from there, if treatment is needed, a referral to behavioral health services can be made. So grief work, as you could imagine, is a big part of what we do in our service.
If it's okay, I'm going to take maybe the last question here and ask, where do you see this program growing and going in the future? And what are the main obstacles that you're facing?
Does anyone want to jump at that, or should I?
I'm going to let you go with that one, Ellen.
I think that we're really proud of what we've accomplished, and there is always a lot more work to do. I think we already touched on one of the areas that you mentioned in terms of trying to be as inclusive of as possible and respond to the diverse needs of the people that come to us and from a variety of different perspectives and life experiences. So that is a priority for us and something we need to continue to do. And I think for me, theme is always around access. How do we find ways to make ourselves available? And I think we've been thinking a lot about the ways in which telehealth has really opened up new doors for us, and thinking about improving access and what are the options that are still available. I think Rose is a really good example of that right now. Rose you have to come to a scheduled appointment, and developing more flexible ways to use technology to make it more available. Project Teach has just become available to us as a consultation for providers, and we have many rural providers affiliated with U of R who don't have the same level of support. And how do we think about making support better available to our obstetrical colleagues in other contexts? With Project Teach providing consultation and support and resources for providers who may not have the same on-site resources available. So I would think those are three of the highlights that come to mind.
Thank you. And thank you for mentioning Project Teach, which has been known as CAPPC for a long time. And this is the New York statewide initiative, which as of January of this year is including maternal mental health into the child portion of it. So that's the expansion. So this is now a maternal child health initiative, and OBGYN and family docs or providers in general can access this consultation service. More to come on that, and we will have brochures and emails to all of you around this topic.
I do want to add one point about from a practice level, we've finally figured out how to make it somewhat financially sustainable also it took a long time, but to bill for Eileen's services, and that's really helped us prove to the people that helped fund us that it was worth the effort. So
thank you, everybody. It's over time. So thank you for all the wonderful work, and we will see you soon. Take care.
Thank you for this opportunity.